So in December of 2019, the first cases of a new virus were reported in China, a respiratory virus in Wuhan, China, and soon thereafter recognized that we had a new virus that had not previously been seen, which was a coronavirus. Many people have been worried about coronaviruses for some time, since the 2003 outbreak of SARS-1, and recognizing that coronaviruses are a type of virus that can readily jump from species to species and could be a cause of the next pandemic for a couple of reasons. Number one, because most warm-blooded animals are susceptible to coronavirus. Secondarily, being respiratory is easily to jump into another species. And so obviously I think many of us are aware that over the last 18 months, we've seen over 180 million cases of this, and significant high morbidity and mortality related to this. And we've all probably experienced it in our practices, in our hospitals. We know that this is a big issue. And so the questions that I wanted to try to address today are four topics that I think are things to be aware of. The current epidemiology of COVID-19, what we can do for prevention for COVID-19, what we can do for treatments, and then finally what is potentially the next epidemic that I think we're going to be facing in our healthcare system are the consequences of long COVID or post-COVID syndrome, depending on what you want to call it. So hopefully we'll cover those four things. We're going to do it expeditiously. I think we're going to try again. So a couple of things. So I kind of wanted to show you to start with some pictures, because I think that pictures of what we've seen and where we've been are really helpful. First off, some pictures. I think most people are, when you get a picture in your mind of what the numbers look like, both globally, and then as we pare down and look at the United States, and then finally look at Alabama. Sometimes it's hard when you see these big numbers, think about that in terms of how that affects me. But when you come down to your local area, even like I like to look at the Jefferson County numbers, then it really takes home. How many cases are we seeing today? How many cases are we seeing per week? How many per month? What's happening in our hospital? These things can be really informative for me. One of the things that we started to initially see here was an increase in the number of our healthcare workers in our healthcare system who were developing symptomatic disease, respiratory illness. And so what we readily recognized is that we needed to institute policies to prevent our healthcare workers from getting infected so they can meet the needs of the patients in our hospital. So we had a very proactive approach that we developed in terms of what was required of healthcare workers to do, not just for their own prevention, but then also surveillance and having them report daily if they were developing symptoms. And then as testing came along, being able to test them to identify symptomatic people, developing a protocol in terms of their isolation and staying away from work, as well as doing contact tracing around that individual in the work environment. And we were readily able to go from having 60 to 70 cases of people, of employees per day, to single digits. And most of the people who, within about 6 weeks' time, and most of the people who were becoming COVID-19 positive were actually getting in the community and no longer at work. So we were able to sustain our workforce through the early phases of the pandemic and meet the need, which was very great, as you remember, last fall and into the winter. the the difficult thing about this virus is that while it is a respiratory virus, it has many different ways it can present. It can present as a viral illness. Number one, it can be sort of like an influenza when it presents in that way, or as a true respiratory illness. These are relatively easy to identify and to recognize that it may be COVID, but there are other presentations that may be less specific, less respiratory. So GI symptoms are quite common. There's not an insubstantial number of people who present with sort of a GI illness. What were you able to get?
I have them.
Oh, you got them up. She somehow was able to. So I'll jump back in. Oh, and you have a pointer. So now I'll use the microphone. Hello. All right, so, see if you can get them into, put them into slide mode so that, all right, great. Now my one challenge is that I'm not going to be able to see the slides, so I'll have to keep looking up. I apologize for that. Let's see. So this isn't working. Will you be opposed if I stand down there and I'll just advance as I go? That might be easier. I can talk loud. Most people in the back can hear me. All right, technical difficulties being what they are. So, once again, as I said, coronaviruses are common. 15% of the time cold are due to coronaviruses. However, coronaviruses have the potential to mutate and then develop these more severe, as I mentioned. Back in 2003, it's working now. We had SARS, and then we've had several others, the MERS virus, and now SARS-CoV-2. Transmission is person to person and generally respiratory. One of the challenges about this virus is that the highest risk of transmission is actually in the 2 days before a person develops symptoms. You have the highest level of virus in your respiratory tract, and therefore you can spread. And so that's why it's really important as we do contact tracing that we're asking people about their exposures in the 2 days preceding to them developing symptoms, so we can identify people who may be infected and get them tested and isolated to prevent this ongoing transmission. These are just some maps, and so I pulled the most up-to-date data from Johns Hopkins yesterday, and I think what you can see, as I mentioned, 187 million cases, over 4 million deaths globally, and you can see here we are in the United States here. And then, here is our current pandemic. This is data from yesterday, and I think these people realize that this is a really nice website if you're interested in knowing what your local risk is in terms of here in Alabama. You can actually pull up the actual data from this website, Global Epidemics, and what it tells you is what is the actual case incidence in any area. And so you may have heard right now we've got these huge Delta variant outbreaks happening in Missouri and Arkansas, and you can see those are the places right here in Louisiana that we have the highest case rates in the U.S. The other thing about this website is it really tells us, it gives us information that I find useful to guide, what approaches we should be doing in terms of our local epidemic. When we have high case rates, then we should likely be asking people to travel less, to try to have less social engagement, and then as we get to a time point when we have fewer cases, we can get back to normal life. So this is a really busy slide, and this comes from another website that I like to look at. It's the goal of the website is to turn COVID on its head, and so it's 91DVOC, which is COVID-19 spelled backwards. So if you're interested in epidemiology, you can look at this website. I just show you this just to show you the Alabama curve. Here we are in blue, and so this is all the 50 states, and you can see there's a lot of noise. Back in December and January, we had this really high spike that came down, and we've been pretty low. I don't know how well you can see here, over the last few weeks, we've started to see an increase in our numbers. And while we still remain low, much of this is attributable to some of the variants of concern, and I'll talk about that in just a second. I think we need to remain vigilant. So COVID really can present as a spectrum of disease, right? If we look overall at the people who get COVID, 80% of people have mild to moderate or asymptomatic disease, and about 20% have more severe disease, many of whom require hospitalization. And so what we really want to do is to be able to identify those 20% of people and get them treated as early as possible to prevent, severe complications. And so those are really the people that we're trying to identify and treat. Symptomatology can be highly varied. While over 90% of people do develop fevers over the course of their illness, fever is not the most common presenting sign or symptom. So we can't look to just fever as the most common thing. So fever, a significant number of symptoms that are related to an acute viral illness, and then a lot of respiratory symptoms are common. Anosmia, or loss of sense of smell, is usually a later event, but is definitely a harbinger. If someone suddenly has an onset of loss of sense of smell or taste, that's a reason to consider for COVID testing. So the early disease, as I mentioned previously, it can present as a number of different typical viral illnesses. Dyspnea, or shortness of breath, usually doesn't occur until later into the first week. And so once again, a person may have some sinus congestion and not really think about it, and that may be the onset. In fact, I will tell you a very common presentation is someone who says, oh yes, this past year we had a lot of rain in the spring. They said, oh, it was my allergies to all the pollen, and then they subsequently developed dyspnea, tested, and had COVID-19. The good thing is we want to try to identify people as early as possible because we've actually developed some treatments, and later on I'll talk a little bit about the treatments we have available, and hopefully we'll have some more treatments come out. So when we think about early disease, it's really important to identify these people, number one, to reassure them, but number two as well, to be able to identify who is more at risk for severe disease, and also to help prevent the onward spread of the virus. Patient education is very important. There's a lot of anxiety. I talk to a lot of patients with a new diagnosis, and there's just a lot of anxiety. So raising awareness, understanding some of the conservative measures that they can take are very important. And then regular assessments. These can be done by phone. These don't have to be done in person, but that can also help you identify people who are progressing to being unwell. And then risk stratification. Clearly we know that certain people are going to be sicker than others. People who are older, people with chronic medical conditions, and these are the people for whom we should have a higher level of vigilance to try to identify who's going to be sick. Here's a list. These are from the CDC website as well as updated from the WHO website. I won't read through these, but I think the sense is someone who's older, who has multimorbidity, specifically obesity, diabetes, hypertension, are going to be at greater risk to have more severe disease. And we should raise our vigilance that these are people that we need to monitor. So really the early part of the disease comes in two phases. There's the early phase, which is the viral phase, and then we start to develop an immune response, and then secondarily there's an inflammatory or immune response phase. So like I said, for 80% of people, everybody will go through the viral phase, and then depending on how robust their immune system and how much underlying debility they have determines how severe the illness they're going to have. And so what you can see is there's really this early viral phase followed by a host response. And when people have more severe host response or they have significant underlying medical disease, then that puts them at greater risk to have more severe or critical illness. Now, one of the things that's happened, obviously this virus evolves, it mutates, and that's likely why it emerged to begin with. But even so now, as it's moving through populations, it has ongoing mutations. Most of these mutations or changes in its genetic code have little impact on anything, but in the face of some type of pressure, like immune responses and whatnot, it will start to evolve or mutate away from those. And so what we've seen is the emergence of variants. With any virus, there are variants. And with this COVID, what we've seen is There's been a move for the virus to move to greater infectivity. One of the things that's consistent with all of these variants is there tend to be more infectious among humans. So you can just see there, right now we have, so the WHO has given them these labels using the Greek alphabet. I think that's a little bit easier. Alternatively, remembering this nomenclature, I always get confused. I can't remember these numbers. And it's not really that useful to say where the virus emerged from, because that's not always an accurate reflection of the virus. But I think when you look overall, for all of them, there's increased transmission. And there's been a lot of concern now about the Delta variant. So it has increased transmission. It has a 50% higher transmission than some of the earlier variants. And one of the reasons is because it induces significantly higher viral replication and higher viral loads. So a person with the Delta variant has higher virus in their respiratory secretions, and therefore they're going to have greater risk of transmission. It also has been associated with increased severity of illness, and part of that also probably relates to the fact that it replicates more avidly in the human respiratory tract, and therefore we have a more vigorous immune response to that. The other thing that we've started to see with some of these variants is the development of resistance to some of our therapies. I'm going to come back and talk a little bit. We've developed therapies, monoclonal antibody therapies, and what we've seen with some of the later variants is they've developed a resistance to one of the monoclonal antibodies. And in fact, the FDA has recommended that we no longer use the bamlanivimab based therapy, because the virus, the Delta variant and the Gamma variant, have significant resistance to that monoclonal antibody. Now, the good thing is we have two other antibodies, the Regeneron product and then another product from GSK, that both maintain activity, so that's good. The second thing that this has implications for is that the virus may be starting to evade some of the immune response generated by the vaccine. Now, fortunately, all of the viruses, the variants we currently have circulating, still are susceptible, but it requires a greater immune response. So we'll talk a little bit. There was a question earlier about the need for boosters, and I'll talk about that very briefly. We probably will need boosters sometime. It may be more because the virus is mutated and we need a more specific vaccine, as opposed to a complete waning of our immune response. So this is just some data from the Delta variant. So we had the Delta variant first emerged in India and then rapidly spread across Europe and became the dominant virus in the UK in a very short period of time. And now what we've seen, in surveillance data, as of March, we had very little Delta. And then over this course of time, we now see it to be over 50%. And depending where you are, you can see there's different rates of prevalence of the Delta being the dominant strain. In Arkansas and Missouri, where we're seeing the big outbreaks right now, 80% of the virus there is the Delta strain. So I think what we need to anticipate as public health officials is to be ready for the emergence of this. So just 5 take-home points about the Delta variant. I do think that this is what we need to be preparing for. We've seen a big increase over the last 7 days here in the United States. People probably see in the news. 93% increase. Much of this is related to this Delta variant. So this virus is more contagious. It induces a higher viral load. So every one person who gets infected, he or she will infect 4 people. That's the R0 value. The original virus infected between 2 and 3, about 2.5 people. So an increase in the number of people that will get infected. Unvaccinated people are at greatest risk for this. The vaccine does afford protection. It's not as protective against the wild type variant, but it does protect people, and it reduces the viral load. It also, if they get infected, it also prevents severe illness. The Delta variant is going to lead to hyperlocal outbreaks, and that's what we're seeing in these communities like Arkansas, Missouri, Nevada. These are hyperlocal. They have these areas of people who are unvaccinated, and the virus kind of explodes in these, and this puts a crushing kind of burden on their local healthcare systems. This virus appears to be more virulent. They're seeing higher rates of usage of ventilators, and they're seeing sicker people at younger ages.
So these are really challenges to think about. Vaccination is the best protection against this virus, and we really need to try to encourage people to get vaccinated. Okay, so talk a little bit about prevention, and just I put this slide up just to remind people this is respiratory virus. Primarily, it's transmitted by droplet, which requires people to get close together within 6 feet for a protracted period of time. The Delta variant appears not to require as long as the wild-type virus. There is some airborne or aerosolization transmission, although this seems to be less frequent. There's a lot of concern about fomites from contact, and while that is possible, it's much less common than initially believed. It really primarily is going to be a droplet exposure, and so being within 6 feet of people for greater than 15 minutes really is what puts people at greatest risk in an inside space. So both Dr. Barney and I will just tell you, we're a little, we haven't been spending that much time indoors with people. Maybe we need to do that and socialize a little bit more, but it makes us a little uncomfortable. Hopefully most of us here today are vaccinated and we can be more comfortable. So just some general prevention measures. So once again, it requires close contact, greater than 15 minutes. We need to identify people. So I think a key part of prevention, and I don't have slides on this, but I think we need to remember it is really important to test people, identify them, and then if they are identified with COVID, make sure that they're isolating away from other people for 10 days to really stop that forward spread. Risk reduction strategies are helpful. So covering coughs and sneezes, maintaining the 6 feet distance. When distancing isn't possible, the use of face masks and frequent hand washing, and then vaccination. So I just have one slide kind of on some of these. There's been a lot of, reports about how useful some of these measures are, and this is a meta-analysis that was published in the Lancet, and just highlights 3 things that I just wanted to focus on. Physical distancing works. So they looked at 9 different studies that were adjusted and 29 unadjusted studies to see if 1 meter, which is about 3 feet, made a difference. And what they saw is people who had a further distance, the risk of transmission in those studies was much lower, 2.6% versus nearly 13%. So a significant benefit with a large or small adjusted odds ratio. Face masks, similarly, a similar odds ratio, 17% with no face mask, 3% for people who wore face masks. And then finally, eye protection. They had 13 studies. And using eye protection reduced the risk of transmission, so those are face shields among healthcare workers. And once again, a benefit. These aren't perfect mechanisms to reduce transmission, but they help and they can significantly reduce them. So these are beneficial, even if not perfect, modes of prevention. Now, a lot of interest has been focused on, can we develop treatments? Can we give people medicines as pre-exposure prophylaxis, so before they ever get exposed, and then also post-exposure prophylaxis? So far for pre-exposure prophylaxis, it doesn't seem to help a whole lot if we take any medicines before exposure. Some of the HIV medicines are active theoretically against SARS, hydroxychloroquine and chloroquine, ivermectin, a number of different vitamins. None of these studies have demonstrated a pre-exposure prophylaxis to prevent infection. Now, monoclonal antibodies theoretically could be beneficial. There are actually studies ongoing, and hopefully those will be published to show that it can actually prevent transmission, although that's a very expensive approach for prevention. Now, post-exposure prophylaxis after a person is exposed may be a more cost-effective approach. There have been a number of studies that have looked at this for both hydroxychloroquine and chloroquine. Neither of those have showed promise. There are 3 studies with ivermectin. Ivermectin is an anti-parasite medicine that does have activity, although the dose you have to give to really have activity in humans is extremely high and potentially toxic to the liver. There are 3 reports of reduced infection after ivermectin administration. These are not controlled studies. I'm not sure that I would base using ivermectin on those. There are additional controlled studies that are ongoing that will tell us whether this is truly a reasonable approach. There are studies recently presented for monoclonal antibodies, an infusion therapy as post-exposure prophylaxis, that demonstrate in different populations that this can actually work. And so I think that we will see this is another potential treatment. I wanted to show two of those studies that were just presented this spring. The first of which basically looked at nursing home patients where they had a source patient, and then they would give the other residents placebo or the bamlanivimab, the monoclonal antibody, and then see who ultimately got COVID. And what you can see here is that rates of COVID were much higher in the placebo than in the monoclonal antibody arm, and it was a significant improvement, up to an 80% reduction of risk of people developing symptomatic disease. There were no deaths seen in the group who got monoclonal antibody, and they did have 4 deaths in the group who got placebo. So this actually can work, and that's obviously a very high-risk population. There was another study that was presented with the Regeneron antibody that was actually looking at household contacts of a positive case, and then they were randomized to receive either the antibody or placebo. And once again, you can see there was no symptomatic infection in the Regeneron antibody versus 8 or 4% in the placebo, and then any positivity. It reduced it by 50%. But what was striking as well, the people who got monoclonal antibody, no symptomatic infections, and they had much lower viral loads. Now, this is a much healthier population, so they didn't really present data on mortality. But regardless, I think this therapy is one as a post-exposure prophylaxis that could theoretically work. Now, it's complicated to give. It requires an IV infusion currently. It has to be done at an infusion center. But it gives us promise that an antiviral therapy can work as post-exposure prophylaxis. Most importantly, I think, for prevention is COVID vaccination. Now, I was going to spend some time talking about these, but I took those slides out. I'm kind of glad I did, just in the interest of time. You know, here in the U.S., we have 3 vaccines that have been given emergency use authorization by the FDA. It's only a matter of time before they get fully approved by the FDA. It just is a slow, long process. 2 of these are a novel approach to vaccination, where we use an mRNA technology to vaccinate and to induce immune response. And so these are the Pfizer vaccine and the Moderna vaccine. So these are the ones that show 94 and 95% prevention of infection when used, and nearly 100% prevention against mortality and severe disease. So these are really effective vaccines. They require 2 doses, either 3 or 4 weeks apart. And this has really been striking how effective that these are. And to just pivot back for just a second, to remember when we're seeing people who are getting sick and hospitalized, since June, the mortality related to COVID has been 99% in people who are unvaccinated. So these vaccines may not completely prevent infection, but they nearly universally prevent mortality. The other is a viral vector vaccine, where we actually take a different cold virus, an adenovirus. It's inactivated, and then we put some of the DNA from this virus into it so we can generate those proteins and induce immune response. So the J&J vaccine is this. And so once again, its efficacy is not as good, only 66 to 72% to prevent infection, but very good as well to prevent severe disease. There's studies ongoing to look at whether 2 doses would induce the same level of protection as the 1 dose. Now, a lot of concerns people have about these vaccines, obviously. One of the concerns is, what about in the face of the variants? And we have some data on those. And before I do that, I think one of the concerns people have is how fast we got these vaccines to market, right, or completed. I mean, we started in December, and then by the next December, we have a FDA approval, or at least emergency use approval. And the question is, people are concerned because that's too fast. But I think when we think about it, a couple of things to begin with. Smart vaccinologists in 2003 recognized these coronaviruses were likely to cause a pandemic. So they started working on developing vaccines at that point, where all they had to do then, if a new coronavirus were identified, they could identify that spike protein that infects people and generate an immune response to that. And so they had the technology kind of waiting in case we had such a pandemic, which happened. Secondarily, we have the technology to sequence viruses much faster than we used to. And so we were able to pull that out, identify the key sequence to generate the immune response. So that was a very fast process. These mRNA technologies are very quick to develop. So basically, once we sequence that part of the virus, we can rapidly develop the mRNAs that will then induce the proteins to stimulate our immune response. There was a lot of support both between industry and government to have combined early phase studies in humans, phase 1 and phase 2, to show safety and get the right dose. And these happened very quickly. And then we had rapid enrollment of the phase 3 trials. Finally, we had a huge background rate of infection at the time, so we didn't need as many people to show efficacy as we might have needed if there was a much lower rate. So all of these things worked together to get us to have a vaccine that was very effective, very fast. Now, we've shown of efficacy. We're going through the approval process, working through the logistics. So there are a lot of questions that arise now as we're in this phase. Number one, optimizing the vaccine and whether we need boosters. What is the real effectiveness? What is the safety? Surveillance and preparation in case some of these variants emerge resistant. And in terms of safety, I mean, obviously we heard reports this week about the J&J vaccine being associated with Guillain-Barré syndrome, and there have been some other concerns. You know, these vaccine side effects are very rare. 1 in a million, 1 in 2 million. Just go back and think, if you get COVID, 20% of people develop severe disease. Death rates from COVID still continue, even in the best circumstances, 2% here in Alabama. So think about the risk of 2% risk of death versus a 1 in a million, 1 in 2 million. I think we struggle to weigh risk and benefits as well as we possibly should, and we should be better able to talk to our patients about risk and benefits. So I think that's a big concern. I do think we want safe vaccines. We want safe medicines, absolutely. We just have to recognize that there are very modest risks that come with anything that we do in life, and so we need to balance those. I think that we fail to fully, as humans, recognize that. So what about the variants? This is a big concern about the vaccines, and are we going to see a reduction in the efficacy? So for the alpha and beta vaccines, which are on this chart, for the vaccines that we have in the U.S., for Pfizer and Janssen, they still maintain similar effectiveness as the original, although maybe some modest reduction overall. Some of the other vaccines, there's been seen a more significant reduction in terms of the efficacy. Once again, here's more data in the post-EUA. What you can see is, once again, a slight reduction in the Janssen. Pfizer maintains similar. The good thing is still really strong protection against critical or severe disease. Now, there is some concern. None of these reports that I've shown highlight the Delta variant, which apparently does have a little bit less reduction, although in vitro studies show that these vaccines still prevent severe disease from these and markedly reduce viral load in people who become infected, although it still reduces the risk of infection. So we should still be promoting the use of our vaccines. This is the best way we have to prevent another surge here in Alabama. Now, there's a lot of vaccine hesitancy, obviously, and I think that we experience that a lot here in Alabama, but across the United States. So about 40%, a little less than 40%, 35 to 40% of people are vaccine hesitant. And there's a perception that means, oh, there's just 35, 40% of people who won't get vaccinated. But that's not really true. There's really 4 different flavors of vaccine hesitancy. So, and 3 of these groups are really probably open to vaccination, with the right kind of coaching and education. So the first group of people are people who are just watchful and just aren't sure. They think, oh, maybe this is just going to go away and I don't need to get vaccinated. I'll just let that happen. And I think that really requires us to be engage them and say, look, this is really important. If we as a community want to maintain health, and if you don't want to get this, it's important. These are relatively easy people to get vaccinated. The second group are people who are cost anxious, and even though the vaccine is free, maybe they don't have the time. Maybe their work won't let them off, or maybe they're concerned they'll miss work if they have symptoms the next day. So there may be some policy changes that need to be made to help these people, overcome their fear so that they can get vaccinated. The third are people who are system distrusters. So they are just not sure, they're not fully assured of that there's equity in terms of the vaccine. These people with education, with knowledge, can also be convinced to get the vaccine. The final group, which makes up about 14% of the COVID skeptics, and these are the individuals that are the most difficult, who are just, perhaps they're anti-vaccinators, perhaps they're really fearful. These are the least likely that we are to convince. But once again, as we raise the number of people who are getting vaccinated, we can change minds. And I know that we've changed some minds of people when we see in the hospital, as I mentioned earlier, the people who are getting severe COVID are unvaccinated. And so talking to their loved ones when they're at their bedside, we can make a difference in terms of trying to help convince them to get vaccinated. Here's our data in Alabama, and so, strikingly, the vaccines came out in December. We rapidly ramped up, and what's been struggling is that we've really fallen sort of off a cliff and have very low levels of vaccine administration in our state now. So, we have high levels of vaccination rates. I always tell myself, thank God for Mississippi, because that keeps us from being number 50. We're 49. So, I'd like to see us go a little bit higher on that list, if you want to know the truth. My colleagues always, try to shame me into something about that. Here's Alabama, and you can see, as a state, most of our counties fall within the 24 to 36% range. Overall, we're just not doing as well as we need to do. Even in counties like Jefferson, Montgomery, or Madison, we need to do better. And then when we look at our age groups, I think the good thing, old people take this seriously, right? Maybe as we get closer to the end, we're like, man, I want to enjoy every minute. When we're younger, like me and maybe some other people, we're like, I'll be okay. But people 65 and over 70% of people are vaccinated. As we get into these younger groups, decreases. And what's really frustrating about this is what they're seeing in these outbreaks in Missouri and Arkansas right now are people in their 20s, 30s, and 40s who are intubated in their ICUs, who are unvaccinated. So the virus is causing more severe disease in younger people. We need to do a better job at convincing these groups to get vaccinated. Now, the 0 to 17, remember, there's only people 12 and up can be vaccinated. So there's a large swath of that population who aren't eligible yet. Hopefully, the studies that we have now will soon be available to generate data so we can vaccinate my 11-and-a-half-year-old at home. Okay, so, prevention, I think I didn't have slides on testing, but just two taking points. Testing is important. If we have someone who we think has COVID, getting them tested so we can stop the spread, get them in isolation. Number two, vaccinating. Those are probably the two most important things for prevention that we as healthcare providers can do. Now, the good news is, since last year we first started this, we had no treatments, and all it was symptomatic management. And what we have developed now is both on the inpatient and the outpatient side, treatments that can be effective to prevent severe COVID. So the first thing that I will just say is diagnosis is crucial. So we want to diagnose people as early as possible. And so when people develop symptoms, we really should be testing. There are two phases to this illness, this viral phase or viremic phase, the first 8 to 10 days, and then this immune phase. And the immune phase is really when people get sick. If we can identify people in the viremic phase, get them access to treatment if they qualify, that can really be life-saving and stop the progression of the disease. treatment is really different based on when someone presents. If someone presents in this viremic phase, we can give them this monoclonal antibody therapy that I just showed you worked as prophylaxis in post-exposure prophylaxis. It also is very effective. We can give it up to 10 days, but really it's most effective if we get people in the first 5 days of symptoms before they've had that immune kind of inflammatory response rev up. And then they have this immune dysfunction phase. We try to avoid systemic steroids in the viremic phase, and the reason being, yes, that can suppress the immune response and improve symptoms, but it also facilitates higher viral replication. So there can be a rebound in terms of the severity of illness if we give steroids in this first 10 days of therapy, particularly systemic steroids. Now, for people with underlying respiratory disease who are having actual bronchospasm, there may be an indication for inhaled steroids during that period, but we really try to avoid systemic steroids. And then really identifying those people who are at higher risk for progression, those people can qualify for monoclonal antibody therapy. Now, adjunctive therapy with a lot of different medicines can be helpful. Making sure people stay hydrated, dealing with diarrhea for those patients can be very critical. There are really no conclusive data that support the use of hydroxychloroquine, ivermectin, or vitamins in this period. Like I mentioned, there's studies ongoing right now with ivermectin. There's some other studies ongoing, but there's been no data to truly support that these therapeutics have beneficial effects for patients with early disease. The good news is 80% of people with COVID are going to do okay. So it's the 20% that we really want to identify. And so we want to provide supportive care, try to make sure they're isolating to prevent onward transmission. We want to triage these people with telehealth as possible, and then identify those people who qualify for monoclonal antibody treatment, and then get them referred onward. We developed and set up a infusion center here at UAB to meet the need. We've treated over 1,000 people now at our center. I know in Montgomery, David Thrasher has treated 600 or 700 people. Down in Mobile, they've treated nearly 2,000. So, our large medical centers have the capacity to give these treatments. What is a monoclonal antibody? So basically, we identified antibodies in people who cleared the virus, and we found antibodies that neutralized the virus. And then we can pull that antibody out, and we can make that antibody in a lab. And so these are monoclonal. Instead of, when we make an antibody to a virus, we make a wide swath of antibodies. But we pick out the one antibody that neutralizes the virus, and then we can make a lot of that, and then we infuse it. This is like passive immunization. And so a person has high levels of these neutralizing antibodies that they can circulate in their body. They bind up all the virus and shut it down and stop it from replicating, rapidly clearing the body, the virus from the body. There are over 25 companies that are working on these. Obviously, there are lots of monoclonal antibodies that we use in a lot of other disease states. Cancer, many of the therapeutics that we use now are monoclonal antibodies. The antibodies the treatments that we use for rheumatoid arthritis, Humira, and others are monoclonal antibodies. And so all we're doing is taking the same technology to develop an effective strategy for COVID. And there were 3 of these that were approved, and now the bamlanivimab, because of the resistance to some of these variants, has been the FDA approval has been, or the emergency use authorization has been removed. We still have 2 products, the Regeneron antibody as well as the GSK antibody, that are very effective. Current outpatient. For people who are sick enough to require oxygenation or supplemental oxygen but don't require hospitalization, that is an individual who we do consider giving supplemental steroids. Generally, these people are into the second week of their illness. There's no current indication for remdesivir, which is the IV therapy that I'll talk about for inpatient, as well as for the anti-inflammatory drugs that have been used and shown to have benefit in people with more severe disease in an inpatient setting. One good news, and I do want to share this, is that we have oral antivirals. One of the challenges with monoclonal antibodies is that it's an IV infusion that requires someone to come to an infusion center and be with us for 2 hours. So there is the recognition that we need oral antivirals like we have Tamiflu for influenza. And so this is exactly what is coming. Molnupiravir. I don't know, why can't they make easier names? Come on. Some of us are, tongue-tied. But, so this is an antiviral that's active against many RNA viruses. And here this data I'm showing you is from a ferret model. And basically it reduced risk of infection. And for those ferrets that got infected, any of you ferret owners out there, you can be relieved. Your ferrets will now have a therapy. So it reduced the risk of infection. And then for the ferrets that got infected, reduced viral load. Ferrets are a good model for coronavirus, so they're used. This has now been studied in humans, and we're going to have a big phase 3 study that we're getting ready to start here. It's really exciting. So this was data that was just presented. So here they had non-hospitalized patients within 7 days of their COVID-19 diagnosis, so very early. And what they looked for was people who had, at 3 days after, they either got placebo or the molnupiravir, and they looked to see if they had viral shedding. At 3 days, there was a striking reduction, 28% versus 20%, and at day 5, none of the people who got the antiviral had virus. So that's really critical because, once again, the second phase, the immune response is to the virus. If we reduce the virus, we'll reduce symptoms, reduce severity of disease. This is what we really need as an oral agent because this is much easier to take and administer than the monoclonal antibodies. So stay tuned. Hopefully, sometime this fall, we'll start to see data coming out from the phase 3 studies. So that's for the people who are outpatient. We do have therapy, but it's limited and it's a little bit challenging. The good news is we've developed some therapies for people who are hospitalized. If people are in the hospital and you need help identifying what the right therapies are, the NIH has developed a website that's specifically about COVID treatment. And I pulled this from that. They identify different groups of people who are hospitalized. And they break it down. People who are hospitalized who don't require supplemental oxygen, people who require supplemental oxygen, and then people who are severely ill in the ICU or requiring either ventilatory support or ECMO. And obviously those are the sickest patients. And so for each of these, they make clear guidance for what the data support in terms of treatment. For the hospitalized patient who doesn't require oxygen, maybe they're in because they're dehydrated, or maybe they've had an MI because of type 2 MI. Regardless, they require supportive care. And then we can consider remdesivir. In general, we don't give remdesivir in this patient because there's not shown to be benefit in these individuals who are relatively well. Now, for people who have supplemental oxygen requirements, there's data that supports the use of remdesivir. Remdesivir is an antiviral that's given IV. This is Nathan Erdman. He led the study as we contributed to data for this here at UAB, and this is a common therapy that's given here. It has modest but true benefits in terms of helping people in terms of both recovery. People recover faster if they're given remdesivir versus placebo, and it also reduced the risk of mortality for those individuals. It seemed to work best for those people who had moderate illness. It doesn't work as well for people that have severe illness. It's likely because this is an antiviral, and we need to get people when they're relatively early and still have viral replication. For people who are slightly sicker, that's when we need to think about immune modulation, and there's good data to support the use of steroids. This is the data from the dexamethasone trial that shows benefit in terms of reduced mortality, the hardest endpoint when we give dexamethasone. There's some other anti-inflammatories. One is a JAK-STAT inhibitor called baricitinib, and here I'm showing the data. Once again, improvement in terms of overall outcomes as well as reduction in mortality when we give this to these individuals who are sick. There's another agent, an IL-6 inhibitor, tocilizumab, another monoclonal antibody, that similarly has benefits in these patients. Here at UAB, we've developed a treatment algorithm. This is available if you're interested on our UAB website. I'm happy to share it with you. And basically, we identify the patients, we stratify them, and then try to make this easy for our providers, both inpatient and outpatient, so they know what's available for their patients for treatment. I just want to highlight for prophylaxis, we recommend vaccination. For asymptomatic, there's really no treatment. For mild outpatients, as I mentioned, the monoclonal antibodies, steroids only in very rare situations. And then we have treatments for the hospitalized, moderate or severe. And once again, these track along with the NIH guidelines, and we're continuing to do studies to try to develop better treatments for COVID. Okay, now one of the things that's happened for me in my practice is we're starting to see people who have these chronic symptoms related to COVID. I think there's a recognition this is not just an acute respiratory illness. There appear to be long-term sequelae for many people post-COVID. And so, here at UAB, we're trying to develop we've developed a kind of a treatment program to be able to help people. But I think this is the next epidemic that we're going to see, is all these people who are left with long-term consequences. So I think one of the challenges is we're just still learning about this. I mean, I think the first people who recognized this were people who were coming out of the hospital last March, April, and they were having persistent symptoms. So they called it long COVID or long hauler. Those were the first names. And there have been a number of different names that have been identified. And we're still understanding what the incidence, what the natural history, and what the etiology of all this is. We can break COVID down into several different stages. A big challenge we have still is we don't have case definitions. Obviously, there's the acute phase where people have acute COVID, and this can last up to 4 weeks. Now, obviously, they're not viremic that whole time generally, but they can continue to have symptoms. And then there's a period of ongoing symptoms from 4 to 12 weeks. And post-COVID, when people have persistent symptoms, and depending on the literature you read, this could start at 4 weeks, this could start at 12 weeks. Here at UAB, if someone is having persistent symptoms after 4 weeks, we recommend our providers, they can refer them into our program. The symptoms are highly variable. They can be any body part, any organ. Fatigue, dyspnea, chest pain, and cough are the most common symptoms. There are many others, and a lot of people report the loss of smell or taste, joint pains, myalgias, dizziness, vertigo, alopecia, loss of hair. There's just a wide range of symptoms that we see. And then one of the things that has been most concerning are the mental health and psychological aspects. I mean, many people have or cognitive aspects. Many people report a brain fog or cognitive impairment post-COVID, changes in mood, persistent anxiety, a kind of a post-traumatic stress syndrome. The concerning thing is alterations in functional ability are very common. There's 3 different reports that I highlight here, and particularly in people who are hospitalized, a large proportion of them report ongoing functional impairments after COVID, 4 weeks and longer. Here, depending on these 3 different studies, between 40 and 60% of people beyond 4 weeks still had functional impairment, inability to do their pre-COVID activities. So definitely there's something happening here, and we're still trying to understand the cause and then treatments to help people get over this. I give a shout out to patients here, because as this was evolving, there was really nothing available. So we talked about the harms of social media earlier, but this was actually a benefit. People were actually able to connect via the internet and develop strategies to understand. So this was self-reporting, a network developed by patients to look at post-COVID symptoms. Now there is probably some bias as people self-selected. They came to this website because they were having symptoms. So in this cohort, 91% of people were having persistent symptoms after COVID, but the goal was to collect data to help inform what this entity was, this long hauler, this long COVID. Over half the people reported having at least one pre-existing medical condition before. So that kind of gets back to the issue is who's at risk for COVID are probably the same people who are at risk for long COVID. They probably have some pre-existing medical condition, but in this report, 91% of people had not fully resolved 40 days after their initial illness. And the symptoms were very similar to what has been seen: respiratory symptoms, and a lot of these: fever, fatigue, loss of appetite, insomnia, and then brain fog, difficulty concentrating. There was a lot of stigmatization early on about why people were still having symptoms, 4 or 12 weeks after COVID. A couple of reports that I think are more useful to those of us who are studying this area is where they've taken cohorts with COVID and follow them long term. It helps us understand what is the true number of people who are developing symptoms. So this is a study from hospitalized patients from University of Washington, and what they saw was about 13% or 31% of people developed symptoms lasting longer than 28 days. And once again, having comorbidities, being older, being at greater risk for severe COVID made people at greater risk for these long COVID symptoms. An international study that involved the U.S., Sweden, and the UK looked at people, and now this included both inpatient and outpatients with COVID, and what they found was about 13% reported symptoms that last longer than 28 days. And once again, older age, higher BMI, some of the risk factors for more severe acute COVID, once again, put people at risk for long COVID. So what's the real number of people who are maintaining symptoms or having long COVID symptoms? It's probably on the magnitude of about 25% or so. But still, that's a substantial number of people who are having persistent symptoms, and we need to try to develop therapies for them. Here at UAB, we developed a program with subspecialists listed here. Pulmonary cardiology and neurology see about 80% of the referrals, but we have a number of other subspecialists who are helping to try to ameliorate some of the symptoms. We have a process in place for both internal and external referrals for providers to refer their patients. The recommendation of these people who are having persistent symptoms is, first thing, seek out their primary care provider to see if some of their symptoms can be alleviated. Many symptoms can be effectively handled in the primary care situation. But what we see is people who are hospitalized are more likely to have more severe symptoms and require evaluation by one of our subspecialists. And once again, people can be referred if they're more than 4 weeks out from their diagnosis. Okay, so that was a rapid tour through COVID. I think that we've made great progress in the first 18 months, but my biggest fear right now is that we're all exhausted from COVID and we want it to go away. I want it to go away. But what we have to recognize is, it is still ongoing. There are places in the U.S. and internationally where we're seeing some of these variants of concern emerge and causing really severe outbreaks. And so we need to remain vigilant, and I fear what's going to happen this fall could be a big surge and could overwhelm our medical centers. We have excellent prevention tools, and we need to take advantage of these. Testing to identify people early, and vaccines, and really encourage as many people to get vaccinated as possible so we can try to prevent or abrogate a surge. These variants of concern are really what we should be worried about. This virus will evolve and mutate away from our therapeutics, and then we'll be faced with new challenges. We have treatments now available both for outpatient and inpatient that can be life-sustaining. We need better treatments. These are decent treatments, good starts. We need better treatments. And then this whole notion of long COVID, I think we're just at the infancy of understanding what we're going to do and how we're going to help people recuperate from that. So I thank everybody for bearing with us through our AV technicalities, and I really appreciate the opportunity to speak today. Thank you.